Usually when we talk about medicine, there's this expectation of precision.
Right.
It's kind of like engineering. You break your arm, the X-ray shows that jagged white line, and the doctor just points and says, well, there it is. The fix is obvious.
Yeah, it is a very comforting way to view healthcare. I mean, we naturally prefer things to be visible and neatly categorized.
Exactly.
And above all, we want the treatments to make intuitive sense.
Right? If you're bleeding, we stop the bleeding. If you're dehydrated, we give you fluids. And if you are struggling to breathe and your oxygen levels are dropping, the most fundamental, universally accepted rule in the book is, well, we give you oxygen.
Which just feels like common sense.
Completely. But today, for this deep dive, if you want to understand the why behind the medical rules, we are looking at a landscape that just completely shatters that intuition.
It really does.
We are exploring a physiological mystery where giving a patient the exact element that keeps human beings alive, oxygen, can actually become a deadly threat.
It operates as a genuine medical paradox. And, this isn't just an abstract brain teaser for medical students either.
Right. Not at all.
This specific paradox dictates the emergency protocols used by paramedics and nurses all over the world every single day when they're dealing with one of the most widespread diseases on the planet.
Right, and we're talking about COPD here. So the mission for today's deep dive is to untangle why the classic textbook explanation for this oxygen paradox was actually just dead wrong for decades.
Yeah.
And we're also going to look at how a group of paramedics in Tasmania helped rewrite the global rules of emergency medicine.
It's an incredible story, but to really grasp how oxygen becomes a weapon, I think we first need a rock-solid definition of the battlefield, right?
Let's do it.
So COPD stands for chronic obstructive pulmonary disease, and the globally accepted standard comes from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD for short.
Okay, GOLD.
Yeah, and they define it as a common, preventable, and treatable disease that's characterized by persistent respiratory symptoms and airflow limitation.
Okay, let's ground that in something concrete for a second. If a patient walks into a clinic, how does the doctor actually prove they have this limitation?
Right, so there's a very specific breathing test involved.
Because you can't just guess, right?
Exactly. It relies on something called spirometry. So the patient blows into a machine, and the diagnostic anchor they're looking for is a post-bronchodilator FEV1 over FVC ratio below 0.70.
Oh, wow. Okay.
Yeah, I know. But that specific threshold confirms, and this is key, not fully reversible airflow obstruction, which is really the biological signature of COPD.
Wait, before we move on, what is that alphabet soup? Fair question. I mean, if I'm blowing into this machine, what exactly is it measuring that proves my lungs are permanently damaged?
Right. So FEV1 is your forced expiratory volume in 1 second.
Okay.
Basically, it's how much air you can violently blast out of your lungs in the very first second of a hard exhale.
Got it.
And then FVC is your forced vital capacity. That's just the total amount of air you can push out overall.
So it's a fraction.
Exactly. If that ratio drops below 0.70, it means you can hold a decent amount of air, but you physically cannot push it out fast. The airways are collapsing or they're obstructed.
And you mentioned the key phrase there is post-bronchodilator.
Yes, that's crucial.
Which means they gave the patient an inhaler, like albuterol, to try and open things up, right? But the ratio stayed low.
Precisely. The obstruction didn't go away.
I think this is where the mental model for breathing problems usually gets scrambled for a lot of people.
Yeah.
Because most of us, we default to thinking about asthma.
Oh, absolutely.
With asthma, the plumbing is just temporarily squeezed. You have an attack, you take the inhaler, the airways open back up, and the obstruction resolves. You're back to normal.
And that distinction changes everything about how we manage the condition. With COPD, even after you administer the medication, the structural damage remains.
It's fixed.
Yeah, the plumbing itself is fundamentally altered. You have chronic expiratory airflow limitation. You simply can't get the air out. But, figuring out that fundamental truth took the medical community a remarkably long time. I mean, for over a century. COPD suffered from a massive field-wide identity crisis.
You know what's wild about this? This identity crisis isn't even a modern phenomenon. I was reading through the source notes on René Laennec, the French physician, who famously invented the stethoscope back in, 1819?
Yeah, 1819.
She was doing these autopsies and kept noticing these bizarre, overinflated lungs. When he opened the chest cavity, instead of deflating like a normal balloon, these lungs just sat there.
Yeah, they were emphysematous.
Right. They failed to collapse because they were trapping massive amounts of air.
It was a brilliant, really early anatomical observation. but the medical field had basically no idea what to do with that information at the time.
Right.
For the entire 1800s and well into the 1900s, there was no single disease called COPD. Doctors essentially treated the downstream symptoms as completely separate diseases managed in isolation.
So what did that look like?
Well, you had chronic bronchitis, which was defined by a chronic, highly productive cough. And then you had emphysema, defined by that structural destruction of the lungs' air sacs that Laennec actually observed.
And because of that division, doctors forced patients into these highly caricatured stereotypes, right? The ones that were taught in medical schools for generations.
Yeah.
They call them the pink puffer and the blue bloater.
Yeah, those labels were incredibly sticky, despite being, frankly, largely inaccurate.
What were they supposed to mean?
So the pink puffer was supposed to be your classic emphysema patient. They were described as very thin, burning a massive amount of calories just to physically breathe, but they kept their blood oxygen levels somewhat normal, hence the pink complexion.
Okay, and the blue bloater?
That was the chronic bronchitis phenotype, so typically heavier, struggling with severe fluid retention and right-sided heart strain. And they were cyanotic, meaning they had a bluish tint because their oxygen levels were chronically low.
But the problem is that human biology rarely fits perfectly into two neat little boxes like that.
No, almost never.
And from the sources, it seems like these stereotypes actually created a major danger to patients, because the classic pink puffer was almost always assumed to be a heavy smoker, which led to this massive blind spot in medicine.
A deadly blind spot, really. I mean, while smoking is undeniably a massive driver of COPD in high-income countries, treating it purely as a smoker's disease ignores the global reality entirely.
Right, because there's a whole other world out there.
Exactly. Today, one of the leading causes of COPD worldwide is indoor air pollution.
Oh, wow.
Yeah, millions of women in low and middle-income countries develop severe COPD from decades of cooking over unventilated indoor biomass fuel fires.
It's tragic.
They've never touched a cigarette in their lives, yet their lungs show the exact same permanent destruction.
And there's also that genetic condition mentioned in the research too, right? The alpha-1 antitrypsin deficiency.
Yes. That is a perfect example of how complex the disease really is.
How does that one work?
So alpha-1 antitrypsin is a protein produced by your liver, and it travels to your lungs to protect them from your body's own immune system.
Okay.
But in people with this genetic deficiency, they just lack that protective protein. As a result, their own white blood cells essentially start chewing up the healthy elastic tissue in their lungs.
Oh my God.
Yeah. You end up with young, healthy non-smokers presenting with severe emphysema.
So you have all these different causes: smoking, indoor fires, genetics, causing this messy mixture of bronchitis and emphysema. And by the 1950s, British doctors were calling everything chronic bronchitis, and American doctors were calling the exact same symptoms emphysema.
Yeah, it was chaos.
You couldn't even compare clinical research across the Atlantic because everyone was just speaking a completely different medical language.
It required a massive intervention. So the 1959 SIBA Guest Symposium in London was essentially an effort to lock international experts in a room and just force them to standardize the terminology.
Long overdue.
Definitely. And out of that meeting and the subsequent work in the 1960s by an American pulmonologist named William A. Briscoe, we finally got this unifying umbrella term, chronic obstructive pulmonary disease.
It seems like the whole point was to stop stereotyping patients and recognize the shared physical problem. And modern Gold-D reports really push back against those old pink and blue stereotypes now, right?
They absolutely do.
Because real-world patients are usually just a messy mixture of both emphysema and chronic bronchitis.
Exactly. Modern medicine has shifted focus away from just staring at that FEV1 lung capacity number we talked about earlier. Now, they focus heavily on symptom burden and the risk of the patient having an acute exacerbation.
How do they measure that?
They use what are called the ABE assessment groups.
Okay.
These groups evaluate how much the disease is actually impacting a patient's ability to walk up a flight of stairs or get dressed, rather than just categorizing them by a single biological metric.
Which is way more useful for the actual patient. But it raises an interesting question about where the boundaries of this disease actually stop.
Sure.
The sources mention asthma-COPD overlap, or ACO. If COPD is fixed damage, like we said, and asthma is temporary reversible squeezing, how do you have both?
This is actually one of the most fiercely debated topics in pulmonology right now. Some patients present with the fixed, permanent structural destruction of COPD, but they also have eosinophilic inflammation.
Okay, wait, meaning what exactly?
Mm.
What are eosinophils doing in the lungs?
Right, so eosinophils are a specific type of white blood cell that typically ramp up during allergic reactions, which is a classic driver of asthma.
Oh, okay.
So you have a patient whose air sacs are permanently damaged from COPD, but their airways are also swelling up from this allergic, asthma-like white blood cell response.
That sounds miserable.
It is. And the medical community is split on whether ACO is a totally distinct third disease entity or if it's simply a case of an unlucky patient developing two very common diseases in the exact same set of lungs.
Right. So if COPD means the lungs are structurally permanently damaged and the patient cannot effectively exhale,
Yeah.
how does giving them oxygen suddenly make that permanent damage worse?
That's the big question.
What is the biological domino effect here? Because it just doesn't sound right.
To unpack that, we really have to look at the first principles of how the human drive to breathe actually works. Because in a healthy person, the primary stimulus that tells your brain to take a breath is not a lack of oxygen.
Which feels entirely backwards to anyone outside of medicine. I mean, we breathe for oxygen.
It goes against every instinct. But your primary drive to breathe is actually triggered by a rise in carbon dioxide.
CO2.
Yes. You have central chemoreceptors located deep in your brainstem, specifically in the medulla, and they constantly monitor the pH of your blood.
Okay.
When CO2 builds up, it turns into carbonic acid, so your blood becomes slightly more acidic. Those receptors in the brainstem sense the burn, basically. They scream at your respiratory muscles, and you take a breath to blow off that CO2.
So where does oxygen come in?
Oxygen is just a secondary backup alarm system. That one is monitored by peripheral chemoreceptors in your carotid bodies, which are in your neck.
This perfectly explains why if you hyperventilate, like taking a bunch of really fast, deep breaths before you jump into a pool, you can hold your breath underwater for a shockingly long time.
Exactly.
Because you've forcefully blown off so much CO2 that your brain's primary acid alarm is totally silent.
Yep.
Your oxygen levels are steadily dropping while you're swimming, but the backup oxygen alarm hasn't kicked in yet to tell you to surface.
That is the exact mechanism. Now, apply that to a patient with severe, long-standing COPD.
Okay.
Because their airways are collapsing and they can't effectively exhale, they chronically retain CO2. Their baseline CO2 levels are always high.
So the alarm is constantly ringing.
Well, at first, yes. But over months and years, the body tries to adapt to this new normal. The kidneys step in and start holding onto bicarbonate to buffer the acid in the blood.
All clever.
It is. But because the pH normalizes, those central CO2 alarms in the brainstem essentially get exhausted. They become desensitized and just stop ringing.
So the primary CO2 alarm is completely broken.
Exactly.
Which means the body has to shift its reliance to the backup system,
Yeah.
the peripheral oxygen sensors in the neck. This is the famous hypoxic-drive that nursing and medical schools taught as absolute gospel for decades.
Yes.
The patient is now breathing primarily because their oxygen is low.
And that theory leads directly to the classic textbook warning. The logic dictates that if you have a severe COPD patient in respiratory distress and you slap a high-flow oxygen mask on them, you instantly satisfy that backup alarm.
Oh, wow.
The peripheral receptors tell the brain, hey, we have plenty of oxygen, no need to work so hard.
But imagine the human body is a large building. Normally, the building relies on a highly sensitive smoke detector that's the CO2 alarm.
I like this.
But the smoke detector breaks, so the building management says, well, we'll just rely on the backup heat sensor in the ceiling. That heat sensor is the oxygen alarm.
Right.
Giving high-flow oxygen to this patient is like aiming a blast of freezing, icy air conditioning directly at that backup heat sensor.
That's a great way to picture it. And because you've frozen the heat sensor, the alarm goes completely quiet. Nobody is opening the windows or running the exhaust fans. The patient's breathing rate drops.
But the building is still on fire.
Exactly. Meanwhile, the fire is still burning. The smoke, the CO2 just gets thicker and thicker, building up to toxic levels until the patient becomes dangerously somnolent and eventually stops breathing altogether.
It is a terrifying but highly logical explanation,
It's a brilliantly elegant story.
which makes it incredibly frustrating that it is mostly wrong.
Yeah.
I mean, if that story is so logical, how did we figure out the textbook was missing the real villains?
Well, the neat little hypoxic-drive narrative started to fall apart under scientific scrutiny starting in the 1980s.
Okay, what happened?
Researchers like Aubier, and later there was a pivotal study by Robinson and colleagues published in the American Journal of Respiratory and Critical Care Medicine around the year 2000.
What did they do?
They actually put COPD patients in the lab. They gave them oxygen, watched their CO2 inevitably rise, just like everyone knew it would, but they meticulously measured their minute ventilation.
Minute ventilation.
Basically, exactly how much air they were moving in and out per minute, to see if they really were breathing that much less.
And the drop in breathing rate didn't match the massive spike in CO2, did it?
Not even close. The drop in breathing, that pure loss of drive we just talked about, only accounted for a tiny fraction of the CO2 retention.
Wow.
The alarm wasn't just shutting off. The researchers discovered that the real culprits driving the CO2 up were largely mechanical and biochemical. The first major villain is ventilation perfusion mismatch reversal, or VQ mismatch.
Okay, let's break down the mechanics of that, because VQ mismatch sounds like a physics exam question.
It does, but the concept is actually a beautiful demonstration of how smart the body is. So, in a damaged COPD lung, there are areas of alveoli, the little air sacs, that are completely destroyed. They don't exchange gas well at all. The body recognizes this dead space. It uses a reflex called hypoxic pulmonary vasoconstriction.
That's a mouthful.
It is, but it basically just means the body clamps down and squeezes the blood vessels shut around those useless damaged areas, redirecting the blood flow to the healthy parts of the lung where the air actually is.
That's amazing. It's actively rerouting traffic away from the bad parts of the lung.
Exactly.
But then we introduced the high-flow oxygen mask.
Right, you flood the entire lung with oxygen. When those tightly constricted blood vessels around the damaged areas sense this massive, sudden influx of oxygen, they are tricked into thinking, oh, the problem is fixed. This area is ventilated again.
Oh, no.
So they relax, they dilate. Suddenly, a massive amount of blood rushes back into those deeply damaged, structurally useless areas of the lung.
Wait. So giving oxygen relaxes the vessels in a way that actively destroys gas exchange.
Yes.
That's like opening all the toll booths on a major highway when half the bridge is out ahead.
That's exactly what it's like.
You think you're speeding things up by opening the gates, but you're just creating a massive, catastrophic traffic jam right at the edge of the broken bridge.
And to take that toll booth analogy a step further, not only is there a massive traffic jam, but all those cars are trapped in a dead zone where they physically cannot offload their passengers, the CO2.
Because the sacs are broken.
Right. The blood is circulating, but it's flowing through physiological dead space where it can't exchange gas. That internal traffic control system has completely collapsed.
Unbelievable.
That's culprit number one. Culprit number two is even more insidious because it happens on a microscopic biochemical level. It's called the Haldane effect.
So the blood flow is reversed. But how does oxygen physically interact with the blood cells themselves to make the CO2 worse?
It comes down to how hemoglobin operates.
Okay.
Hemoglobin is the protein in your red blood cells that carries oxygen to your tissues, but it also helps transport carbon dioxide back to the lungs to be exhaled.
So it's a two-way transport?
Exactly. However, hemoglobin has preferences. Deoxygenated hemoglobin loves to carry CO2.
Makes sense.
But when you flood the blood with pure oxygen, the hemoglobin binds to that oxygen and actually undergoes a physical shape change.
Really?
Yes, and because of that new shape, its affinity for carbon dioxide just plummets.
So it basically kicks the CO2 out of the car.
It forcibly dumps its entire payload of CO2 directly into the blood plasma. Now you have a massive surge of dissolved CO2 arriving at lungs that are already damaged, already suffering from a traffic jam, and structurally incapable of exhaling it fast enough.
Wow.
The CO2 levels in the blood skyrocket, creating severe hypercapnia. And this happens entirely independently of how hard the patient is trying to breathe.
Okay, so if the primary danger of oxygen isn't just that the patient forgets to breathe, but rather this incredibly complex mix of reversible blood flow and biochemical dumping, how does this change the actual treatment for a paramedic in the field?
That's a great question.
Does it matter why the CO2 goes up as long as you know oxygen causes it?
That tension dominated emergency medicine for a decade. The physiological debate over VQ mismatch and the Haldane effect was fascinating for researchers, sure, but the paramedics in the back of the ambulance just needed to know, what do I set the oxygen dial to right now while this patient is struggling?
Exactly. Tell me what to do.
And that question was definitively answered outside the laboratory, in the real world.
Which brings us to the 2010 Austin trial, published in the British Medical Journal.
Yes.
This wasn't in a sterile lab. This happened in the back of moving ambulances in Tasmania.
Right.
I mean, imagine being a paramedic in the back of a bouncing ambulance trying to manage a crashing respiratory patient, and you are part of a study that is about to change global protocol.
It was a brilliantly designed, high-stakes, landmark study.
What did they do?
Paramedics treating patients with suspected severe COPD exacerbations were randomly divided into two groups.
Okay.
One group provided the old standard of care, unrestricted high-flow oxygen.
Blasting with it.
Right. The other group provided titrated oxygen. They carefully controlled the flow to keep the patient's blood oxygen saturation in a very specific narrow window, 88 to 92%.
Just 88 to 92%, which feels really low to a lot of people.
It does, but the results from those Tasmanian ambulances were staggering.
Yeah.
The group that received the carefully titrated lower dose oxygen had roughly a twofold reduction in mortality compared to the high-flow group.
They halved the death rate just by turning the oxygen dial down.
It provided undeniable, real-world proof that giving too much oxygen was lethal. It forced ambulance agencies and emergency rooms globally to rewrite their protocols.
Which is fantastic.
But it also revealed a deeply dangerous flip side to this knowledge.
Because if you drill it into the heads of every medical student and nurse that oxygen kills COPD patients, you breed a culture of fear.
Exactly. The pendulum swung entirely too far in the other direction. Providers became so terrified of the hypoxic drive and causing hypercapnia, that high CO2, that they started severely undertreating patients who were actively dying from a lack of oxygen.
Which is horrifying.
Imagine a COPD patient who is having a massive heart attack or a pulmonary embolism. Their oxygen levels are in the 70s. Their heart muscle is dying. Yet you have providers hesitating to give them oxygen because they see COPD on their chart.
Which is a tragic overcorrection, because the golden rule highlighted in the sources is absolute. Hypoxemia, low oxygen, kills faster than hypercapnia, high CO2.
Always.
A high CO2 level might make you sleepy, alter your mental status, and eventually stop your breathing over a period of hours. But a profoundly low oxygen level will cause fatal arrhythmias and stop your heart in minutes.
To combat this fear-based hesitation, organizations like the British Thoracic Society had to write incredibly explicit emergency guidelines.
What do they say?
The mandate is not avoid oxygen. The mandate is titrate, don't withhold.
Titrate, don't withhold.
Right. If a patient is at risk, you use specialized equipment to safely thread the needle. They use things like a Venturi mask, which utilizes different colored valves to draw in-room air and deliver precise, controlled concentrations of oxygen, like exactly 24% or 28%, to safely hit that 88 to 92% target.
You give them exactly enough to keep their organs alive and their heart beating, but not so much that you trigger the VQ mismatch and the Haldane effect.
Precisely.
The protocols have become so precise that some severe COPD patients now carry physical oxygen alert cards in their wallets.
I love those cards.
If they collapse in public, the paramedic can pull out the card and it literally instructs them, my target saturation is 88 to 92%, do not over-oxygenate me. It takes the guesswork out of an incredibly chaotic, high-stakes moment.
When you pull all of this together, the history, the changing demographics, the cellular biology, it paints a picture of a disease whose global burden is only accelerating. The World Health Organization consistently ranks COPD as a top global cause of death. Even as smoking rates decline in some Western countries, our global populations are aging, and urban air pollution is worsening.
It's not going away.
No. The chances that a provider will encounter someone with COPD, or that you, listening to this, will care for a family member with COPD, are incredibly high.
And understanding the why behind the medical rules is what separates a good practitioner from a great one.
Absolutely.
If you only memorize the old hypoxic-drive story, the broken fire alarm, you might be paralyzed by the fear of causing high CO2 when a patient is having a heart attack.
Right.
But if you understand the mechanics of VQ mismatch, the shape-shifting of hemoglobin and the Haldane effect, and the hard, real-world data from the Tasmanian ambulance trial, you realize that the clinical rule isn't about fear.
It's about precision.
It's about knowing that titrate, don't withhold, is a tool that allows you to safely walk the tightrope between saving the heart and protecting the lungs.
It serves as the ultimate example of a textbook mechanism being wildly oversimplified for decades, yet the resulting clinical rule, when properly understood and applied, still saves lives every single day.
It really forces us to rethink everything we assume is settled in medicine. We started today talking about the expectation of precision, like reading a broken bone on an X-ray.
Mm.
Give oxygen or don't give oxygen. But today we saw how a reflex as fundamental, as ancient as the human drive to breathe was completely misunderstood by the brightest minds in medicine for nearly half a century.
It's humbling, honestly.
It is. So I want to leave you with a final thought to mull over as you go about your day. If our scientific understanding of something as basic as oxygen could be this muddy and this oversimplified for this long, what other classic foundational rules being taught in hospitals today might be driven by completely misunderstood mechanisms? What other deeply held medical dogmas are just sitting out there waiting for their own Tasmanian ambulance trial to prove them completely spectacularly wrong?